Hello everyone, I'm back again and I'm so excited to be here sharing my journey, spreading awareness about endometriosis. I think is the motive that keeps me going. And awesome. So let me just check for Dr. Hemant. So Dr. Hemant is here and couldn't have been happier.
Thank you so much, Shilpa. I hope I'm audible and good evening to you and to all your lovely audiences.
Absolutely. Oh, I'm so happy that you could make it to our channel. I mean, this has been long awaited.
Absolutely. And it's been my absolute pleasure to be here with you on your wonderful channel. I know you have some uh, great number of subscribers and you've been doing great job, creating this kind of awareness and helping so many patients and ladies suffering from this dreadful disease called as endometriosis. And I'm really thankful to you for getting
No,
me and for having me over
absolutely.
here. Thank you so much.
The entire purpose of Endo Strong is to make people suffering with endometriosis stronger, and I mean, joining me are people like you who just take us ahead with our ideation. So thank you. So
My
for people
pleasure.
who don't know Dr. Hemant is a gynecologist and an endoscopic surgeon practicing exclusive endoscopic surgery since 2000. A master's degree in Gynac from prestigious KEM Hospital, Mumbai, a diplomat from the National Board, New Delhi, and a member of the National Academy of Medical Science. He's trained in France for advanced gynecological endoscopic procedures. Apart from his work, he's also very passionate about teaching endoscopic surgeries to his fellow gynacs, and he has special interest in complex gynac endoscopic surgeries and excision surgeries for endometriosis. So that's what Dr. Hemant is for all of you. So, Dr. Hemant, first question. You've been practicing for more than 2 decades. What got you interested in endometriosis?
So when I started initially my career, it was just routine gynec endoscopy. So actually, I'm a hardcore surgeon. I always had fascination for surgery, and actually, general surgery was my first choice, but I couldn't make it into it, and so I took up gynec, which is offers me that surgical adrenaline rush. So I took up
Absolutely.
gynecology, and I started my career. I was always fascinated by the laparoscope and the endoscopic approach for surgery, and that's why I took up this laparoscopy and endoscopy right from the beginning of my career, immediately almost after I passed my MD from Cleveland. But then as we went further down the line, we realized there were some complex issues, which we were not really programmed to handle because we were never taught those in our residency program as part of our training. And we had to depend on general surgeons and urologists, to take a lot of help from them. So, and I always like to explore and expand my horizon of, surgical skills. So at a particular point, I thought, I have to expand my horizon, and the gynecologists per se are trained just to focus on the uterus per se as an organ. Okay. But there are many other important organs around the uterus, like the bladder, the urinary bladder, the ureters, which carry urine from the kidney to the bladder, the sigmoid, the large intestine, and the rectum, which carry the stool outwards. Okay. So I wanted to make the entire pelvis my domain, by removing that phobia of operating in the pelvis. And that's why I took it upon myself, to train myself to hone the skills further and to develop into what we call now as a pelvic endoscopic surgeon. As I told you now, the entire pelvis, which starts from the level of the sacral bone or where the lumbar vertebrae ends, right up to the pelvic floor is our domain. And now we are, equipped to manage any condition within that space. And that's why we are called as pelvic endoscopic surgeon. So the basically this surgical adrenaline rush that you get, motivated me to go into this. And then ultimately endometriosis was such a dreadful disease. When we started off, even we used to do, sort of a half-hearted job because we were not trained. And let me tell you, 10, 15 years back, it was the incidence was not so much. What we are seeing in the last 15 years, it's exponentially increased, at least in our subset of population. And it needed special kind of an attention and special care. And so that is the reason I took up this, and obviously helping females suffering from that dreadful pain of endometriosis and the dreadful symptoms is also motivated me further to, go deep into this.
Absolutely, it makes sense completely, and it is much needed because there are so few people who really do the proper excision surgery that is required for endometriosis. And I really feel that there should be more doctors like you, Mimi, or Dr. Sandesh for that matter. I think we need more doctors like you. So you are doing a lot of surgeries for deep endometriosis, right? So how difficult is it, and what needs to be taken care of when you are doing a surgery for such a patient?
So let me at the outset tell you the surgery for endometriosis is considered as the pinnacle of complex surgeries. It is more difficult than a routine surgery for cancer also. You can ask oncosurgeons for that matter. Because what happens in endometriosis is there is complete distortion of the anatomy. By anatomy, I mean in a female's pelvis, there is a normal relationship, anatomically speaking, between the uterus and the surrounding organs. Endometriosis causes complete havoc and chaos in the pelvis. It alters everything, especially the advanced stage 4 endometriosis or the deep infiltrating endometriosis. So there's complete distortion of the anatomy. All the organs get stuck to each other. There's no clear plane of differentiation as you would see in a normal female between the organs. These surgeries are really complex because they stand a risk, a very high risk of the surgeon injuring a particular organ if he's not really prepared to deal with these kind of surgeries. And that's why they are very difficult surgeries, and they require special set of skill sets. Basically all people who are having special interest or focus in this, who are known as endometriosis excision specialists, should ideally be carrying out this surgery in the first go itself. So that would be really helpful to the patient and do justice to the patient.
Absolutely. Like we've always said, the first surgery has to be the best surgery. A person cannot keep going through surgeries over and over again. And repairing something which has gone bad is always more difficult. So, how important is it to diagnose endometriosis at an early stage? And what are the advantages of being diagnosed early?
See, it is very important that diagnosis of endometriosis happens as soon as possible. But the problem with endometriosis is there's no specific screening test to pick out the subset of females suffering from this. The only thing that we can at the moment rely on is the symptoms of the patient. There are no blood markers or a blood screening test or any test as of now which can screen out these kind of females. So as such, because of various reasons, there is a delay in diagnosis. Now, what happens is, typically speaking, this is a progressive disease. It causes a lot of damage within the pelvis over a period of time, and especially by the time it gets diagnosed. And we all know that the average delay in diagnosis is around 8 to 10 years. So you can imagine how much damage this endometriosis can do within that span of time. So it's very important that we pick up the red flag signs, that is mainly the symptoms, in a very standardized manner. There is good awareness amongst the physician also, which is required. And picking up these signs and working towards the management of endometriosis is the only way out.
So, like in every session, probably what comes up is taking a proper history and listening to the patient is what really helps when it comes to diagnosing endometriosis at an early stage, right? So, with this comes my next question. A lot of doctors would be annoyed, but still, how prevalent is medical gaslighting?
Yeah, so there's a proper term in the medical jargon listed as medical gaslighting. So this is a situation where the female or the patient is suffering and is, actually debilitated with her symptoms. And she's expecting some kind of help from either the supporters around her or from the physician himself whom she has approached. But the problem is these symptoms sound very similar to what a normal female might be undergoing. And probably the physician also doesn't understand the intensity of these symptoms. So what happens in gaslighting is, these symptoms are neglected. The patient is, dismissed off as probably some sort of a psychological problem, or she's, basically overreacting to a normal situation. For example, the menstrual pain that's called as dysmenorrhea. Okay. So it is considered like 100% of the females should, as a rule, it's a cardinal rule that they should have menstrual pain, right? So normally endometriosis patients approach with this kind of symptoms, especially the adolescent girls with painful periods. Now, any painful period which is debilitating so much that is affecting her routine daily function. Say, example, there is a school going girl who is having a lot of absenteeism because of the pain, a college going girl, a female who is losing her productive days in life more often than not to this kind of situation. These are red flags, and these should not be neglected by physicians, and they should not be dismissed off as some psychosomatic problem. So it's quite prevalent, but we can get down this incidence by creating awareness amongst the physician. I don't directly blame all the physicians also, because probably it's not been part of their training program, and they have not, many of them, even the routine gynecologists, have not been exposed to this kind of a situation. Okay, so we need to create that awareness not only amongst our patients but amongst our physicians and family physicians and routine gynecologists also. So I think these kind of your programs will definitely serve that purpose.
That's the entire purpose of us doing this, because the more the awareness, the better the facilities would be, the better reach to the people of endometriosis. And somehow it is also because it's a women oriented disease, the amount of importance that it should get, it hasn't been. Like hysterectomy, I mean, I was reading somewhere it was called hysterectomy because people at that point in time used to think that women are hysteric, you know. I mean, just to think about it, imagine the kind of things that used to happen and that still happen. Honestly speaking, I know of people who have been dismissed left, right, and center. I have been dismissed so many times. Um, but anyways, that's how it is. So you also do a lot of pelvic floor repair surgeries.
Yeah.
So what and when exactly is a pelvic floor repair surgery is required?
So pelvic floor is formed by a certain group of muscles which prevent the gravity from pulling the organs down. When we are, say, in a standing position, automatically the organs should get pulled down. But there are certain muscles and ligaments on the pelvic floor which prevent these organs from descending down. So when this fascia is damaged, it could be because of various kind of traumas like birth trauma, repeated deliveries, or it could be even a defect in the fascia, a genetic deficiency in the fascia which is made of collagen. Okay, or a congenital deficiency also is possible, because we see it in young females who have not had a single delivery also. So when this fascia becomes defective for some reason, okay, these organs start coming out from the natural orifices like the vagina. Okay, so that is where we need a specific repair for these kind of patients. Now we divide these into compartments, like the anterior compartment, posterior compartment, and the middle compartment. And each compartment has a specific way of getting repaired surgically. Sometimes we might use a foreign material like a mesh. It's a polypropylene mesh to support the tissues and anchor them to bony points in the pelvis so that they act as a support and prevent the fascia from prolapsing downwards, or strengthening the fascia, because the mesh will subsequently cause some amount of fibrosis and will cause further thickening of this fascia and will help in better support of the organs overlying it. So these females typically complain of something coming out from the natural orifice like vagina. They might have urinary problems like incontinence, leakage of urine, or other problems like increased frequency of urine, and even some problems related to passage of stool. So it's important again, these again can cause social problems, okay, or even sort of sexual problems for the females. So it's better that they get diagnosed on time, and laparoscopy is the best way to repair this because the amount of magnification and precision that we get on a laparoscopic surgery, the kind of access we can have deep in the pelvis was never possible with laparotomy or an open surgery. So laparoscopic surgery is the best approach for these patients, and they do quite well after a good optimum surgery done in the right manner for the right indication.
Okay, so there's a question. I am taking it right here because it is very related. So stress urinary incontinence, why does it happen in women who have never been pregnant?
As I told you, there could be some defective formation or congenital defect in the fascia. So between the bladder and the urethra is the terminal tube which carries the urine out from the bladder to outside. So if there is a variation in the angle between the bladder and the urethra, or the paravaginal tissues which are supporting the bladder are loose, the normal anatomical angles change. And because of this, there is stress urinary incontinence. So whenever you strain or whenever you apply any sort of intra-abdominal pressure, the female can leak some amount of urine. It can be mild, moderate, or severe. Okay, so even a young female without deliveries can face this problem, but we have very effective ways of repairing this or solving this problem, either through a mesh, which can be placed vaginally only, okay, or, known as the TVT or the TOT, or you can do a laparoscopic approach also, and either put mesh or just simple stitches to support the tissue and hitch them up so that the angle is restored to normal.
Get that. I get that. So, getting in a patient's pelvis, and not going through a proper imaging can land you up in a lot of surprises. So, how important is imaging when it comes to endometriosis surgeries?
Let me tell you, at the moment, imaging is the best bet we have for diagnosing or early diagnosis of endometriosis in a most minimal invasive manner. The other gold standard is putting a laparoscope directly and having a look, but that involves a surgical procedure and requires anesthesia. As I told you, there are no screening or markers for endometriosis. So when the patient has these kind of severe symptoms and which are not, getting resolved by routine medications like painkillers and the symptoms are progressing over a period of time. In fact, we assess the pain on a visual analog score. We have a scoring system from 0 to 10 for the pain, which helps us at least quantify the pain and helps the patient also quantify her pain, and which gives us an idea about the severity of the symptoms. And when that is there, the pain score is very high, it is better to evaluate with a good imaging system. Now, the good imaging system could be a good ultrasound done by a specially trained radiologist who has the know-how of dealing with endometriosis pathology, or by an MRI, which is magnetic resonance imaging, again done by a radiologist who again has a good experience in picking up these patients, because anybody can take images, but reading those images is also important and correlating it clinically. So I normally sit with my radiologist and we have had discussions over a period of time, and the sensitivity and specificity of they are picking up the pathology has increased tremendously, more than 95 to 97%. So some of my patients, just they fly out of Mumbai, just come in over here for an MRI. Maybe they might get the surgery done later, but they come in, they get an MRI done, and we discuss the images together and we reach a conclusion as to how we are going to manage the problem. A good ultrasound is also good enough because it is very easily accessible, a cheaper alternative, but it is very operator dependent on picking up the pathology. There are a lot of gynecologists also who are trained in this and are doing a great job at picking up endometriosis. In fact, there are a lot of endometriosis excision surgeons who do their sonography themselves, and they are doing a good job at it. But it all requires good amount of training and exposure, and it's simple. What the mind knows, the eyes will obviously see or even think about it. So that's the crux of the situation.
Absolutely. I completely agree with what you have said. If you don't even want don't even know about endometriosis per se, you will not even see that. So, Dr. Hemant, there is a question that can endometriosis cause the urinary incontinence? And is there any medication, is there any medical perspective to it also?
Yes, for the urinary incontinence, it is very unlikely endometriosis can be a cause of urinary incontinence. As I told you, it is just anatomical changes in the relationship between the organs and the angle between, say, the bladder and the urethra, which really causes the incontinence. Incontinence also could be because of intrinsic urine deficiency or the sphincter deficiency in the urethra, which is the final passage of the urine outwards into the vagina or close to the vagina. Okay, so there are certain medications which are definitely given as a first line management. And what is important is to know the cause of incontinence. There are multiple causes. So evaluation by an expert, by a right person, either by a urogynecologist or even a gynecologist who has a special interest in this, proper evaluation with urodynamic studies. It's a special study which evaluates to the cause of the exact cause of incontinence, and this gives a better idea to the person managing it, the physician, as to whether the patient needs medical management or she needs surgical management. There is definitely a role of medical management, and most of the physicians, the first line of management for them is medical management.
Absolutely. And there was another question saying that a lot of doctors recommend an open surgery instead of a laparoscopic surgery. How can a patient know if a laparoscopy is a viable option or not? Can a patient make that out?
See, there's always two ways to a coin. Okay, there are many physicians who are not trained in the laparoscopic approach. They would definitely prefer doing the laparoscopic approach, but that doesn't mean that that is the right approach. Okay, what the patient needs to know is what is the gold standard these days for that kind of therapy. Taking a second opinion or an alternate opinion always, helps the patient in making a, well informed decision. Okay, finally, it is up to the patient. But let me tell you, laparoscopy is the minimal invasive technique of going into the pelvis. It really offers great magnification. The anatomy, which we never saw on open surgery in our training days, we can definitely now see it in a magnified manner on laparoscopy. So I think it is already the gold standard. There is no debate now. And most of the procedures, I think almost all procedures now can be done very well laparoscopically with great results. In the early 90s, 2000s, it was sort of considered a gimmick, that this won't stand the test of time. But over a period of time, 3 decades, and it's absolutely stood the test of time. And you have so many patients as a testimonial to this. So I don't think so. That's a cause of concern. Also, should be a matter of debate in the patient's mind. Only thing is go to the right clinician and get an alternate opinion. It will definitely help you.
So, what do you think about the medical management of endometriosis? And when I know it is recommended to in certain cases, so what kind of patients are, suitable for the medical management?
See, although me being a hardcore surgeon, okay, I would definitely say there is some role when used for the right indication of medical management of endometriosis. Okay, when there is early stage endometriosis, say an ovarian endometrium. Now, for that, let me tell you the types of endometriosis. There is ovarian endometriosis. There is superficial endometriosis where the involvement or the invasion is less than 5 millimeters. Then there is the deep infiltrating endometriosis where the infiltration of the endometriosis into the peritoneum goes to more than 7 millimeters. And when the adjacent organs are invaded, like the rectum, the sigmoid, and the ureters, the bladder, these are all organs surrounding the uterus. Okay, so in early stages, say if the endometrioma size, endometrioma is nothing but collection of chocolate fluid within the ovary. When the endometrioma size is say less than 3 centimeters, the female, wants to hold on for a surgery. She's not symptomatic or, having debilitating kind of symptoms. Definitely you can try with the medical line of treatment and follow up whether the size is decreasing or not. A person who does not want to undergo surgery immediately, wants to buy some time for whatever reason before complex surgery, they can be put temporarily on a medical management because it will suppress the symptoms temporarily. So I'm going to emphasize on that word. It's a temporary thing. The moment you stop the medical management, the severe symptoms are going to come back. Okay.
Come back.
Yeah, and any person who does not probably desire the complex surgery, basically they are worried about the morbidity because these are ultimately high risk surgeries. I mean, even if done by the expert, the probability of injuries and complications are less, but it's not zero. Let me tell you that. Okay, the chances are there definitely. So if the patient doesn't want to take any risk at all, she might opt for a medical management. Okay. But any disease which is deep infiltrating, which is causing severe symptoms, which on imaging is giving you evidence of, involvement of the various structures in the pelvis, that patient definitely requires surgical excision of endometriosis because the medicine is not going to work on that. Okay, let me tell you, endometriosis is a disease where there is endometrium-like cells in the peritoneum. It's not exactly the endometrium which is lining the uterine cavity. This is similar, but there are constitutional differences in these cells because their receptors are different. They might not respond to the drugs which you're giving, especially the deep variety, and they cause a lot of fibrosis, inflammation. This is an inflammatory condition. There's release of a lot of oxygen-free radicals. There's inflammation, and that's why the things get stuck inside. So there's nerve entrapment also in this fibrotic tissue. Fibrotic tissue is nothing but thickened tissue. So the medicine will not reach over there. So there's no point giving medicine when it's not going to act on that tissue. And something which is invading the bowel wall or the bladder wall or the ureter definitely requires surgical excision because the medical management is only temporarily going to suppress your symptoms to some extent. It will not reverse the pathology. It will probably not delay the progression of the disease also. So this should be absolutely clear in the mind of patients and even physicians and routine gynecologists, because what is projected by the pharma companies is that this is a magic pill and it's going to do wonders to the patient. And most of the physicians also fall in this trap and they go for this kind of management. So this should be very clear to the patient, and we need to create this awareness amongst patients.
So there is a question, how long can one be on medical management for endo or adeno?
See, according to me, no medical management should be carried forward for more than 6 months. At the max, if worse to worse, if the patient doesn't want to have this surgery at all, or you want to delay it further, a year, but we have seen patients with files coming all over from India and sometimes from out of India, taking this medical management, some magic pill or some injectables, for years together, 4 years, 5 years. The last patient I saw, she has come to me for a final surgery for endometriosis, was put on OC pills, for suppressing her pituitary axis. For the last 17 years, she underwent a laparoscopy 17 years back, okay, and her physician put her on OC pills for the last 17 years. That's absolutely insane because these drugs are also going to have some sort of a side effect. These are hormonal drugs. They are going to have definitely some amount of side effects, and some of them, like injectables, can cause severe side effects like osteoporosis and all. So it's not the right thing to do for the patient, I feel.
And what I've seen, I mean, with my personal experience, I can say that a lot of doctors push you into medical management, not telling what really can be done to avoid further damage. And also, what I feel is the side effects is something which have never been told to the patient. So it's not an informed decision that the patient takes. Till the time you don't know what can happen and what kind of damage the medication, especially the injectables, can do.
Sure.
I think there are. It's absolutely insane. There are litigations against that company giving those injections, producing those injections. But then, because it is a big pharma industry, there is no stop to it, no end to it. It's still being pushed into the treatment. But I don't know. I
I
think
totally understand. See, the market factors are going to come into anything, any kind of a product, be it a
correct.
soft drink or be it a medicine or
Absolutely.
a tablet. Okay, but I think it is our onus, and the onus lies upon us physicians to educate our patients. See, I always have a cafeteria approach to my patient. I give them a menu card and I tell
Absolutely.
them in a well-informed manner, in best possible manner, they understand even by drawing sketches. Okay,
Yeah.
these are
Yeah,
your
I've seen your
options.
sketches.
Yeah, yeah. So I think that makes things easier for the patient. So I counsel them
Absolutely.
for almost
Very,
45
very.
minutes to 1 hour. So the thing is, they are well informed, and then I tell them that you make a choice. Now you know your options, you know the pros and cons. I can guide you, but finally it's your body. You need to take an informed decision with the, you know, with the knowledge of the consequences that you want to go in for this kind of an option. So I'd never impose, I mean, most of the good clinicians never impose their own decision right away on the patient. They are just there to guide your patients in the right manner and let the patient take a choice. And I encourage my patients to take a second opinion also, so that, probably they get much more convinced about what they need, but definitely from an equivalent expert and not from, anybody and everybody.
True, true,
Yeah,
true,
yeah.
true.
So the
Absolutely.
phobia, see
Completely agree.
the phobia with general physicians or with the routine gynecologist, this is a complex thing. They want an easy way out with the medical management because they think that's an easier option. Most of them are not trained to perform these surgeries, so they don't want to reroute the patient to another physician. I mean, I'm telling you a fact, and everybody knows this. So they want to try and manage as much as possible. And some of them genuinely think that this will help the patient. Some of them genuinely think that surgery is not for this because they have never upgraded their knowledge. They are still living in the previous era when it was thought probably that surgery is not going to complicate matters further. But things have evolved over a period of time. You need to upgrade and evolve yourself with the changing scenario, with the changing technology. Now things are better, and there's a lot of evidence-based study which is saying that surgery is really helpful in improving the quality of life of the patients, in allowing them to lead a dignified life, free from either free from pain or at least reduced pain. Sometimes the patient might not have a completely free pain kind of a scenario, but almost all patients have improvement in symptoms so that they can lead their life in a proper manner and carry out their routine functions for a longer period of time with lesser chances of recurrences. Yeah, obviously the less chance of recurrences when it is done in the right manner by the right surgeon at the right time, then the chance of recurrence is less than 20% over a period of 5 years.
Absolutely. That's where my next question was coming. That what is the probability of a recurrence?
Yeah, so see, it's very difficult to point that out. Okay, there are various studies, but if I want to put a number which the general audience can remember, after 2 years to 20%, after 5 years, 50%, they can remember it this way. But we have had good number of patients. Okay, these are not anecdotal things that I'm telling you. It's really our experience, and not only my experience, experience of other surgeons also who are doing this kind of work. That if a good excisional surgery is done in the first sitting, the patient hardly comes up, with those kind of symptoms what they already had. They might probably come up. Now, last week I operated a patient whom I had operated 8 years back. In between, she had a kid also, and now she came up with a recurrence of an endometrioma. She didn't have so much pain at that time. She had debilitating pain. We did a conservative surgery. We, saved her uterus. She was young also at that time. She was around 35, 36. Now, after 8 years, she came back and she said she wants everything out because she's completed, her child bearing, and she doesn't, want to keep her uterus and ovaries inside because she doesn't want any more recurrences. But she was not so symptomatic. So that's what I'm trying to tell you, that the quality of life, the impact of quality of life of these surgeries, properly done excisional surgery, is tremendous.
I completely agree with what you're saying. I mean, I have seen the kind of a difference that a surgery makes, to your life. I mean, from a 10, I have come down to at least too, which is like a very, very good thing. And
Absolutely.
there are certain other problems I'll not deny, but obviously they are not something which the endo is causing right now.
True.
So uh, there are a couple of questions. Okay. All right. So the question was, does one need to take hormones post surgery to avoid recurrence?
Yeah, in some cases, suppose if you are doing a conservative surgery, okay, where the fertility is an issue, the patient wants to conceive, okay. So let me tell you one thing, endometriosis cannot be eradicated from the body, okay. It is a situation like diabetes, where you can control diabetes, but you can't have a 100% cure. So you might have microscopic endometriosis implants in the body. Now, we as surgeons, we can remove only what we see, and we can see the best with the laparoscopy vision because the magnification is around 30 to 40 times than with the naked eye. So whatever visible macroscopic implants we see inside, we excise them. Okay, but there could be a chance that the microscopic implants are there. Sometimes a nodule is so close to a vital organ that we have to, exercise something called as surgical wisdom, the risk versus benefit of excising that nodule. If a critical organ gets damaged, the morbidity might be much more than keeping that nodule behind or a small part of the nodule. So this is something also called as economic radicalism. So we have to be radical towards the disease, but behave in an economic manner towards the function of that organ so that the function is at least preserved. Because this is not
Correct.
ultimately cancer. We can't give that kind of morbidity to these patients, which can be expected in cancer, because in cancer, you need a zero clearance, because you don't want any kind of recurrence. That's fatal. Endometriosis is not fatal. It impacts the quality of life. It can be fatal if it progresses beyond a point and, really causes critical problems in the critical organs like the ureter and all, or the kidney. It can cause a silent kidney death also if it causes complete obstruction of the ureter. So what we need to do in certain cases where we are being a bit conservative, we need to give hormones as a backup for a certain period of time to suppress those symptoms. But if we are doing a proper radical surgery where we are almost removing everything, the uterus, the ovaries, and excising all the visible peritoneum and the endometriotic nodules which are deposited on the important organs, including the rectum and the bladder, ureter, then at least I never give any post-op hormone, because I'm quite sure I've excised everything. But let me tell you one thing, just doing a simple hysterectomy and removing the ovaries is not a solution. The patients need to remember that excision of endometriosis is important. Even doctors have this myth that if we knock out the ovary, the hormones will go off and the patient will not have symptoms. But let me tell you, endometriosis is a very puzzling disease. It's an enigmatic disease. These cells of endometriosis, which are there, these are special kind of cells. Okay, they have the tendency for clonicity. That means they divide on their own. They promote self-growth. Okay, they invade the surrounding tissues. They defy the laws of apoptosis. That is natural cell death that should happen because they keep on growing. Okay, they promote themselves in the cells. They can secrete their own estrogen and estrogen hormone and propagate their own growth. So in short, this is like a cancer only, but it doesn't spread to other organs and it doesn't spread at the rate of cancer, but it definitely does invade the surrounding organs in a dangerous manner. So let us understand. So that's why it's important to understand the pathology and the etiology behind endometriosis. And that's why the person who understands this best is an endometriosis expert, not a general surgeon, not an oncosurgeon, not a urologist, because this disease behaves very differently. Only those people who are focused on this disease with a special interest know about this disease and should be managing this.
Perfect. So, so when I was operated, my surgeon, my gynec surgeon, told me that I had a frozen pelvis. So I, being from this fraternity, understand what a frozen pelvis is. Could you just explain to our audience what exactly is frozen pelvis?
So as I told you, the normal female pelvis has certain organs like the uterus, the bladder, the rectum, the sigmoid large intestine, the ureters, the ovaries. So the normal anatomical relation between these organs in a standard pelvis is maintained, right? That is what we read in our textbook, the normal anatomy. Okay. But in frozen pelvis, due to some kind of pathology, now let me tell you, endometriosis is one of the commonest causes, but there are other causes like, some kind of an infection in our population, mainly TB or COX of the pelvis, or it could be multiple previous surgeries also. So these cause a reaction, like endometriosis is an inflammatory chronic disease. They cause a reaction within the pelvis, whereby all the organs stick to each other. So the entire normal anatomy is distorted, as you would see in a normal female. And that is what we call is a frozen pelvis. But let me tell you in the lighter vein, I always tell this in my presentation, a frozen pelvis is one which, temporarily freezes the mental and cognitive ability of the surgeon who is not equipped in managing this kind of a condition. It can really freeze his brain when he sees that,
Yeah.
if you, especially when he's not trained to manage it. So that's why I call it, that's another metaphor for a way of expressing what a frozen pelvis is.
Absolutely. I can completely imagine.
Yeah.
So now going forward,
Yeah.
how how do you think mentoring the newer gynacs would help?
Yeah, I think again the onus lies upon us. Now we are sort of senior gynecologists, so we need to pass on our knowledge and the skill sets to younger generation because they are the future. So I have this passion of teaching endoscopy to the young students as well as the consultants or who are there in the practice for a long time, whoever is willing to learn. So it's very important. And the problem is still in the residency program in majority of the places. They are not taught to deal with the entire pelvis. Okay. Barring a few institutes where they are trained, but the general gynecologist is not trained to handle this problem during his residency program. So when they come out, they have to, do some sort of a fellowship, and that is where mentoring is important, guiding the younger generation, making them aware of the anatomy. So in these surgeries, the anatomy relationship is very important. As I told you, there's nothing like a normal anatomy. So we need to really find out the planes. We need to know our landmarks in the pelvis of the important organs, which act sort of a GPS within the pelvis and guide us, that this is normal and, we can proceed further in this manner. So this, our new generation or the new students need to learn. And yeah, we are doing our bit by educating them, by exposing them to this. And I think this is the best we can do to help our patients actually.
True. So there are somebody has just asked adhesions. How can you stop them from happening post surgery?
And so adhesion is a very individual thing. Okay. During surgery, we take all the care, or there are various standardized steps to prevent adhesions, including some things that we use like adhesion barriers and all. But ultimately, in my experience, it is the patient's tendency which is most important. Okay. Two patients can undergo multiple operations and they behave differently when you go inside. So I go sometimes to the Gulf to operate, and there I have operated on patients because they undergo multiple cesarean, multiple deliveries. So we have operated on patients who have undergone or done a hysterectomy for a patient who has undergone 6 cesareans previously, or even 8.
Oh,
Okay.
okay.
But let me tell you, yeah, it does sound terrifying. But sometimes a patient, and they are quite bad, the adhesions are quite bad in these cases. But sometimes we see similar kind of adhesions in a patient who has undergone 1 or 2 cesarean also. So it's basically the tendency, and you can't do much in terms of medication or diet to reduce those adhesions. You just got to accept what you have and how your body is going to behave with it, and be prepared for the next surgery by choosing a good surgery.
So Wendy, how do you choose the right doctor? I think it's a different topic altogether. We're going to do a session on that completely with an endo warrior, because I think the endo warriors, the kind of research that they do for finding a good doctor, I think it's uncomparable.
Absolutely.
And removing ovaries would stop estrogen production. Yes, of course it will, but it will not stop endometriosis for sure, because it produces its own estrogen. So, Dr. Hemant, anything that you want the doctors to do while dealing with patients of endometriosis?
First thing, listen to your patient intently. It matters a lot. Okay, the patient symptoms. I feel the entire endometriosis management should be symptom centric, because, as I told you, this disease behaves in a very funny manner. You have various stages of disease from stage 1 to stage 4. Sometimes you'll see a stage 4 patient of endometriosis absolutely asymptomatic. We are doing a scopy for something else and we find all adhesions inside, but the patient never had any symptoms. Okay, for these patients, our policies don't trouble until trouble troubles you. You know, so it's simple. But sometimes we find a stage 1, stage 2 with severe symptoms. So go all out and do justice to this patient. Pick up the red flag signs. Okay, severe menstrual pain, severe dyspareunia, that is painful intercourse. Okay, severe dyschezia, that is painful passage of stool, severe dysuria, painful passage of urine, and chronic abdominal pain, by which I mean a long standing abdominal pain. Anything which is, affecting the routine daily activity of the female, causing loss to her productive days in her life, impacting her psychologically. These are red flag signs. Don't neglect them. Don't belittle these symptoms, and act accordingly and investigate further to at least rule out some form of endometriosis by guiding them for a proper investigations, proper imaging, and ultimately, if the patient requires any sort of management, sending them to the right person at the right time, so that the first surgery done is the best one, because the patient has that is the best shot for the patient towards managing that disease and reducing her symptoms. So, in short, just be aware of these things, and I think it will do great justice to your patient.
I hope people are listening and understand what you have said. So, there's a question from my mom.
Oh,
Okay, because she knows I'm not going to ask. So,
no, you should,
so,
and please
so
do convey my regards to her, and you should
I
thank her,
would.
especially asking that question. I'm honored your mother is asking that question. Thank you so much.
So she's asking that for a person like me who's had a hysterectomy, oophorectomy years back, and having menopausal symptoms. Uh, so now the doctor has advised me to take a minor dose of estrogen. Okay, so my mom worries how easy is it to get the endo back if I'm taking an estrogen pill?
I think if you're going to take a low dose estrogen pill, the
1 mg.
chances are less. Yeah, the chances are less,
Hmm,
but you need to be watchful. You need to
hmm,
get yourself screened on a regular basis. And
hmm,
if you can try for alternative sources of this, like there are some natural resources, isoflavones, and these things, along with the holistic approach of exercise, yoga, supplementing along with this, then it would be really helpful. But if the postmenopausal symptoms are quite severe, affecting you, then I think it's worth giving a try to the hormonal pill in a low dose, and be watchful of your symptoms, because endo is not going to come overnight, right? We'll definitely give you some warning signs. So I think
yeah.
you can try it, and in all probability, since you have undergone a complete surgery, I'm okay. I think I'm putting a bet that it's not going to come back.
Even I'm hopeful that it's not going to come back. So, so anything for our viewers, doctor?
For the viewers, see, you might be having someone in your family, yourself might be suffering, someone in your family or close contact might be suffering, again, you also have to listen to these people and, listen to them intently. Don't sort of neglect the symptoms. Approach the physician early. Don't think that this is a routine thing and you got to really, most of the time females think, I just need to develop the courage to fight this sitting at home. And this is especially when they see the other females around, having their menstrual pain also. And, most of them don't get affected so much. And probably they think that if I report this, I'll be, called out sort of, I'm whining or wimping a lot. So don't, drag yourself down. Don't lower your self-esteem. Approach the right physician. Find out a right physician. There are people like Dr. Shilpa Rao who are always willing to help so many people. And they're doing a yeoman service. It's a great service that they are doing to the society and the female population at large. So you can approach them and get to the right physician. Listen to what he has to say. Explore your options. What you have. Make a well-informed choice as to what you want to undergo. Take another opinion if required, so that clears the whatever cobwebs are there in your mind, and then go ahead with good faith in God. Have good faith in God. See, these surgeries, I normally tell my patient it's a calculated risk. Sometimes there is a thin line between taking a calculated risk.
Can't hear you. Yeah. Yeah.
There's a thin line between taking a calculated risk and being foolish. Taking a calculated risk sounds sensible in these cases. So you got to weigh the pros and cons, have faith in God, and what I call is take the leap of faith. And more often than not,
True.
If you go with good faith, everything happens fine.
That's right. That's right. So somewhere that attitude, your mental framework really matters. And for me, it has really helped. I always think to myself that it is not coming back. I'm going to be fine and I'm sure I'm going to be okay. And I have amazing people around me, so I have all good vibes. So I'm sure people also have to, all my endo warriors also have to keep a mindset which will just take them ahead, and keep faith. Keep faith. It is going to happen. So Wendy is like, she doesn't want the session to end. And can you share the doctor's details? Yes, of course. We will share Dr. Hemant's details. We will put it down in the comments section. And Dr. Hemant, it was honestly a wonderful session and really, really very insightful. It was amazing. Look forward to a lot of more sessions with you and look forward to a lot of patients getting help from you in future also, and wish you all the best for all the surgeries that you do.
Shilpa, before I sign.
Yeah, now I can.
Yeah. Before I sign off, I would like to immensely thank you for having me over and inviting me and getting this session on. And I'm really thankful to all your audience for logging in live and giving their precious time to listen to us. I sincerely hope this was helpful to them and all will help them in some manner or help some of their contacts where they can spread the message. And if there's anything I can do for any of them, I would be more than happy. It would be my absolute pleasure because nothing gives me more joy than reducing the pain and suffering of a patient suffering from endometriosis. So that's, really, that's what gives me adrenaline rush. Apart from doing the surgery, the symptomatic improvement is what actually gives me an adrenaline rush and motivates us to, go further and further, helping patients. So thank you so much once again. And it was a great session with you and looking forward to many more of these. Thank you. Bye-bye. Good night.
Thank you so much. And thanks to all our audience who have joined us live and to everyone who's going to watch it recorded. Thank you so much for supporting us always. Thank you. Have a good evening. Bye-bye.